is the most important question is which thyroid medicine is the best? We'll talk about the importance of measuring T4 and T3, not just TSH. We'll talk about the difference between desiccated thyroid and synthetic thyroid hormones. We'll show some new articles showing patients prefer desiccated thyroid. We'll talk about new thyroid hormone preparations. We'll talk about T3 alone. And we'll talk about, is reverse T3 important? Can people see me? Tiffy, can the people see me?
Let me see one sec. We can see the slides.
But not me?
I can see you up on your screen. Yes, we can see you.
Okay, great. We'll talk about, is reverse T3 important? We'll talk about, does biotin affect thyroid tests? And we'll conclude by talking about a hypothyroid diet. The thyroid gland is in the center of the neck here. You can see it on the picture here. It's right above the trachea. Now, there's many options for thyroid treatment. We'll talk about these, most of them today. These include levothyroxine or LT4 or levothyroxine alone. This is generic levothyroxine, Synthroid, Levoxel, tyrosine, and Unithroid are the main brands. We'll talk about T4 gel capsules, tyrosine, generic tyrosine, and Thiquidity. We'll talk about T3 preparations, Thyronine is the generic Cytos brand. We'll talk about T4, T3 combinations. We'll talk about desiccated thyroid. The new one that's quite excited about is Adthyza, Armor, Nature Thyroid, WP Thyroid, Urfa from Pig Thyroid. These are often called desiccated thyroid or NDT or desiccated thyroid extract, DTE. We won't talk much about thyroid gold. This comes from New Zealand cows. It's actually probably a reasonably good product that's available over the counter. We'll talk about desiccated thyroid T4 and T3 combinations. We'll talk about proper thyroid treatment needs to be individualized. You don't always give everybody the same blood pressure pill or the same cholesterol pill. You need to individualize that. And part of this is important because multiple studies have shown a poor quality of life among patients on levothyroxine replacement alone. Some, but not all studies have shown benefit of T4, T3 combination of T4 alone. A large study done in Italy in 2011 found that patients without a thyroid given levothyroxine replacement, 15% of them had a low serum free T3 level, but normal TSH levels. This suggests that for certain patients have a different set point for TSH secretion, and that some patients need T4, T3 combinations to achieve a normal free T3 and free T4 level. And when you think about it, since the thyroid makes both T4 and T3, your chance you're going to have low T3 levels. And this was a very important paper that came out. It was a meta-analysis done in 2020 by Fitzgerald and colleagues. Clinical parameters are more likely to be associated with thyroid hormone levels than with thyroxine levels in systemic review and meta-analysis. The authors concluded that thyroid hormones levels, in particular free T4 levels, seem to have stronger association with clinical parameters than do TSH levels. The clinical research components of thyroidology currently based on the measurement of thyroid state by reference to TSH levels warrant reconsideration. So this is a figure here that shows the proportional results that shows this statistically significant association with a clinical parameter. The free T4 and the free T3 were highest. There's a little more variation with the free T3 or total T3. And then both of these were quite high. The TSH had a very low correlation with clinical parameters. And this supports measuring free T4 and free T3 on patients on treatment, which I do. And I think it's okay, as we'll talk about more, to have a low TSH, especially people on desiccated thyroid or T4, T3 treatment, or patients with pituitary problems. They often have the low TSH. And it also supports replacing T4 and T3 either by combination treatment or with desiccated thyroid. Another important study that came out in 2009 was by Paniker. His group found that about 16% of patients have a polymorphism. This means a change in their DNA into type 2 deiodinase that converts T4 to T3. Patients with this polymorphism require higher T4 dosing and had more psychological problems than those that did not have this deiodinase polymorphism. And they didn't examine whether these patients would benefit from T4, T3 combinations, and did not actually measure the enzyme. They only looked at the gene coding for this enzyme. And these intriguing papers challenge the idea that all patients with hypothyroidism should be treated with T4. And I use different combinations of thyroid medicine, including T4, T3 combinations, and desiccated thyroid that actually has T4 and T3 yet. And as I mentioned, we don't use one blood pressure medicine for all patients. And although there's some data that suggests that a good portion of people, and I think got my county job at Martin Luther King, I have many patients that are on T4 alone and they do fine. But not all patients can. I think you have these about 15 to 20% of the population that does need T4, T3 combination or desiccated thyroid to have an optimal effect on the thyroid. Some of this may be due to the high reverse T3 that T4 alone can lead to. And these patients are often the vocal minority or not doing well on T4 alone treatment and would benefit from seeing a thyroid specialist like myself. A desiccated thyroid has a higher T3-T4 ratio than the human thyroid. Many patients on desiccated thyroid have a high free T3, a low free T4, and a low T3. And some patients, and this I think is a little less so with the NP thyroid than other preparations than compared to ARMOR, but you have to look out for both free T4, free T3, and TSH. ARMOR thyroid is made by by AbbVie, that's been distributed by Allergen USA. And there used to be concern about variability of preparations and lack of standardizations, but now they're unfounded, and there's studies show that ARMOR thyroid is very standardized. AbbVie has over 60 products. Some of the other preparations that we'll talk about, or we'll mention at least, is WP Thyroid. It was a brand of desiccated thyroid with minimal binders and fillers. I used to use it extensively, but it hasn't been available since I think about 2019. My guess is it's probably not coming back. And so both of them, WP Thyroid and Nature Throid, are made by RLC Labs, and I don't see them coming back. NP Thyroid was recalled in 2020, but not recently. So I think NP Thyroid is also a great option. So important thing to think about is the T3, T4, T3. The T4 has a long half-life, the T3 has a short half-life, and desiccated thyroid has T3 in it. So T3 or desiccated thyroid needs to be given twice a day. And the people that give it once a day, I just think they don't understand the physiology behind T3. It's really a hormone that's gone from your system in about 6 to 8 hours or so. So if you take it once a day, the T3 is gone by the evening. You're hypothyroid in the evening, you're really hypothyroid the next morning, and you don't do too well once a day preparation. It needs to be twice a day. The second dose can be given about 2 to 3 p.m. And then in desiccated thyroid, because it comes from a thyroid extract, it has other things that are missing in synthetic preparations like T3, T1 and T2, and there's other preparations that are in the desiccated thyroid that are not in synthetics. And I give it in patients that are not doing well on T4 alone, which is most of the patients that come to see me. And I would say most of the time the doses should be separated from food by about 45 minutes. I think this 4-hour idea is not really true. 45 minutes to an hour is probably a good amount. So I'm going to talk about a couple important studies done at the Walter Reed Medical Center in Bethesda, Maryland. The first was a study that came out in the best main journal in endocrinology called Journal of Clinical Endocrinology and Metabolism. It was a randomized crossover study in which 70 patients completed the study and received either desiccated thyroid or levothyroxine replacement. Patients were on a stable dose of levothyroxine and had a normal TSH before the study started. 78 patients were randomized, 70 completed the study, with 35 receiving ARMOR thyroid at the beginning and 35 receiving levothyroxine at the beginning. The dose of either the levothyroxine or ARMOR was adjusted after 6 weeks, so TSH was between 0.5 and 3, and they continued on that dose for an additional 10 weeks. After 16 weeks, the patient was switched over to the other compound with the same adjustment. At 6 weeks, continued for another 10 weeks. So overall, there was not a statistical improvement in symptoms for general health questionnaires and neuropsychological testing. However, there was a trend toward these improvements in the group that took the desiccated thyroid compared to the levothyroxine. There was a 2.9-pound weight loss among the group that took the desiccated thyroid compared to the levothyroxine group. The patients on ARMOR did have a slightly lower HDL, which is a good cholesterol, which is a little bit detrimental. Both total T4 and free T4 were much lower on the ARMOR than on the levothyroxine replacement. And that indicates that some patients on desiccated thyroid, especially those on Armour, can need an additional levothyroxine, and I often prescribe levothyroxine to these patients. However, the reverse T3 was higher than the levothyroxine-treated group, which may be detrimental, and therefore these patients may not benefit from T4 in addition to their Armour thyroid. And as I mentioned, I see less of this low T4 in Adthyza and other thyroid preparations. Most importantly, 49% of the patients preferred Armour thyroid and 19 preferred levothyroxine, and 33 did not know a difference. This was a blind study, and they didn't know which thyroid preparation they were taking. And this indicates some subtle improvements in how they were feeling with the Armour thyroid that didn't come out when they did their surveys. This is a very important fact, is that people like being on Armour. They felt better. That's the most important thing. The subgroup that preferred Armour thyroid lost even more weight. They lost 4 pounds on the Armour thyroid compared to levothyroxine. They had better well-being, and their thyroid symptoms were significantly better with better cognitive function on Armour thyroid compared to when they were on levothyroxine. Again, this was a crossover study, so we can compare what they were on each of the two drugs. And this suggests that a subset of patients need Armour thyroid as opposed to levothyroxine. These may be poor converters of T4 to T3 or have some other problem. Most importantly, there were no significant side effects in the Armour thyroid group. There was no increase in heart rate or pulse. The authors concluded that improvement with Armour thyroid may be detected by the relative insensitive methods used in the study in different surveys. They also included that once-a-day desiccated thyroid in place of levothyroxine caused modest weight loss and possible improvement in symptoms and mental health without appreciable adverse effects. So overall, I find this was a very well-designed study, a well-executed study, and by a reputable group in a superb journal. And I note that the Armour thyroid was given as a single dose once a day without levothyroxine. And since Armour thyroid has T3 that has a short half-life, Armour should be given better. And I think if the patients did get the Armour thyroid twice a day, they would have even done better than on once-a-day Armour thyroid. And this study certainly refuted the claim that Armour thyroid is inferior to levothyroxine. And the study also pointed out the importance of trying to determine the subset of patients to be put on desiccated thyroid. Clearly, a subset did prefer the desiccated thyroid. And these people were more likely to have autoimmune thyroid disease, had a higher reverse T3, although neither of them were significant. And the other issue about this study is it examined all patients with hypothyroidism on levothyroxine replacement. Most of them were doing well. If they did a subset of patients who were on levothyroxine and feeling poor, I surmise that they would have done even better on the desiccated thyroid. Many of the patients who come to see me or have a low quality of life on levothyroxine replacement, and if your doctor refuses to prescribe desiccated thyroid, shown in this article, or the next one we're going to talk about, or better yet, come out and see me or make an appointment to see me remotely. And this was followed by a study that came out in 2021, also in Journal of Clinical Endocrinology and Metabolism. I did meet Dr. Hong at the Endocrinology Society at the project booth and talked to him about the study. At that time, this was in 2021. It was an abstract that he published it shortly thereafter. And this was a follow-up study. This was a prospective randomized crossover study. 75 patients completed the study. This time there's 3 arms: desiccated thyroid extract, levothyroxine plus liothyronine combination, and T4 alone. And it was blinded as to treatment. Each subject was randomly allocated to one of these 3 arms for 12 weeks and then crossed over. So this is basically how it went. There was 95 eligible, 90 randomized, 15 due to transfers or they weren't available. So 26 received T4 alone, 27 received T4, T3, 22 received desiccated thyroid, and then they were crossed over to, after 16 weeks, to the other arm, and then to the third arm after another 16 weeks. There were 75 at the end here, so this was like a triple crossover study. Overall, 45% of the patients indicated they preferred desiccated thyroid as their first choice, 32% preferred T4, T3, and 23% preferred T4 alone. Again, this was blinded, so the fact they liked one indicates that they felt better on it, basically. Again, desiccated thyroid was the best, T4, T3 was the second best, T4 alone was lagged behind. There was no significant difference between the 3 arms on the thyroid symptom questionnaire. They looked at secondary endpoints of weight, general health, depression, memory, lipids, thyroid function. There was no significant difference between these groups. And they actually did look at that polymorphism that we talked about earlier in the Panicker paper. It did not affect the outcomes. Dr. Wong gave a talk at the Endocrinology Society, and it was like a product booth. There's a picture of him. I think this was from his oral presentation. It was sponsored by Acela that makes MP thyroid. It was well attended. And it talked about once-a-day thyroid use, which he advocates. And he also advocates monitoring TSH. Both of those I disagree with. He also mentioned several other studies showing increased patient satisfaction with desiccated thyroid. And you can see the slide here from his talk. So I'll go over a little bit about some of these other studies. He talked at this product demonstration also in his article. Subgroup analysis based on the scores of symptoms questionnaires. They found that symptomatic patients on levothyroxine improved while being treated with T4, T3, or desiccated thyroid. So they found that the people that were still symptomatic on T4 did better when they switched over. And he said reports of improvement in switching to desiccated thyroid were notable. He was quoted, it was an interview afterwards, many patients when switched from T4 to desiccated thyroid said they felt much better with more energy, less mental fogginess, a better outlook, less flare of lupus syndromes, and easier to lose weight, etc. So in his study and his presentation at Endocrinology Society, he was quite impressed with the effects of desiccated thyroid. So my comments on the second paper was that this is a blinded study, which is good. There was a small number of participants, but clearly desiccated thyroid was more preferred than with a lower number preferring T4 alone. They did pick patients specifically with hypothyroid symptoms again. Probably those with hypothyroid symptoms will do even better. Desiccated thyroid should be given twice a day. This was given once a day. And he aims for a normal TSH. I aim for a normal to high free T4 and free T3. And it's okay to have a suppressed TSH. So I'm going to briefly go over some of these other articles. Again, there's 7 of them. Most of them are not that well done, and most of them are not in top journals. This was one called Thyroid Stimulating Hormone Stability in Patients Prescribed Synthetic or Desiccated Thyroid Products, a retrospective study. They found there was no difference in the stability of the thyroid medicines, and they looked at their TSH, and it was pretty stable. This one published in Southern Medical Journal was in 2018. Patients were started on combination therapy if they complained of hypothyroid signs and symptoms despite optimal trials of levothyroxine monotherapy for at least a year. And they continued to have low normal free T3, 2.5 to 3. And whether they wanted to be on natural desiccated thyroid or synthetic T4, T3 was based on their position preference. They have a graph here showing sort of the opposite way of looking at it. There was no patients on desiccated thyroid that had hopelessness, while there was 84% on that had that on T4, T3 combination. Feeling downhearted, only 12% felt downhearted on desiccated thyroid and 24% on T4, T3. I feel somewhat ill, pretty low percentage. So in general, in these questionnaires, the people that were on the desiccated thyroid felt better than the ones on T4, T3. So they're concluded that in our subset population, the symptoms of hypothyroidism improve significantly with no increase in hyperthyroidism. The abnormally low TSH and elevating free T4 and free T3 levels persisted only for a short duration because of dose adjustments in very young patients, and they didn't find any difference in levels according to the etiology of hypothyroidism. This was sort of a report done by Pepper in Florida that talked about improved patient satisfaction with the treatment of hypothyroidism. The patients that received desiccated thyroid or armor thyroid, and in this case, felt much better compared to T4 alone. Again, no side effects were seen. And this is a paper published in Medicina that looked at using mixed methods study to evaluate the content of online posts from 3 popular hypothyroidism forums on patients currently taking desiccated thyroid extract. It looked at 673 people. Nearly half of the patients reported that a clinician initially drove their interest in trying desiccated thyroid. Patients described many reasons for switching from a previous approach to desiccated thyroid, including lack of improvement in hypothyroid symptoms, 58%, and development of side effects, 22%. The majority of patients described desiccated thyroid as moderately to majorly effective overall and more effective than the previous therapy, 77%. So quite a large number preferred it on this online survey. The most frequent described benefits associated with desiccated thyroid use were improvement in its symptoms, 56%, and change in overall well-being, 34%. 1/5 of the patients described side effects related to the use of desiccated thyroid. Another article looked at online survey of hypothyroid patients demonstrate prominent dissatisfaction. This was posted on the American Thyroid Association website and forwarded to multiple groups. Respondents were asked to rank satisfaction with the treatment for hypothyroidism and their treating physician. Respondents reported the therapy they were taking, whether it's T4, and T3, are desiccated thyroid. Individuals taking desiccated thyroid reported a higher median treatment and satisfaction of 7 compared to the other treatments. At the same time, the T4 alone exhibited the lowest satisfaction of 5, and for the T4, T3, it was 6, basically in the middle there. Respondents were taking desiccated thyroid were also less likely to report problems with weight management, fatigue, and energy levels, mood, and memory compared to those taking T4 or T4 plus T3. So in summary, there are 7 peer-reviewed articles, some in good and some in not-so-good journals, that show that desiccated thyroid is preferred over levothyroxine, and some articles over levothyroxine plus liothyronine. There was no studies that showed that T4 was better than desiccated thyroid, and several studies showed that the side effects, including hyperthyroidism, were minimal. And the bottom line is patients feel better on desiccated thyroid, and there's a Medscape review here with a link there that sort of summarizes several of these articles. Now, is there a problem with having a low TSH? Probably not. And I would say there's 2 organs that can be affected by too much thyroid medicine and a low TSH. As I mentioned before, the clinical symptoms don't seem to correlate with a low TSH, both the negative and positive ones. The 2 main organs that are affected is the heart and the bones. You can have high bone turnover with hyperthyroidism. And what I do to alleviate that and make sure that I'm not over-treating and giving people detrimental effects on their bones that could lead to osteoporosis is a urine test called a urine N-tyl peptide. It's a second urination in the morning. Its concentration is in bone collagen equivalents over the concentration in creatinine. The range in LabCorp and Quest is about 5 to 65. So I like it sort of in the range. As long as it's not above 65 or above 60, I'm quite happy. And it shows that they were probably not going to be breaking down much bone if they are taking that. If they do break down bone, I often put them on vitamin K2 as a supplement to help protect their bone. And I would do this test every 6 to 12 months. The other potential problem with overtreatment in a low TSH is atrial fibrillation, where you have a rapid heartbeat. This is unlikely to occur in a young person. I would use it with a little more caution in an older patient using desiccated thyroid, but I think it happens very rarely. So in general, I would recommend people to take their thyroid medicine, especially desiccated thyroid or T4, T3, in the morning, an empty stomach, 45 minutes from food. Take the second treatment in mid-afternoon. Avoid taking with iron, calcium, vitamins with iron or calcium, proton pump inhibitors, Carafate, which is a medicine that's used to treat esophageal ulcers or stomach problems, oral bisphosphonates such as Fosamax, orlistat. And the last one's the most interesting one is cholestyramine. Cholestyramine is used infrequently to lower cholesterol, so I would almost never mention that. However, it's been making a comeback to treat mold. So a lot of patients that are on treatment for mold seem to be on cholestyramine. So that's the one medicine that people should separate from their thyroid. And I would say my reading of the literature is there's a fairly minor effect of soy. Soy may interfere a little bit with the absorption, but not that much. Okay, so let's talk about some of the different thyroid preparations. We'll start with Armour. Armour's been around for 100 years, since the 20s. Armour was a company that produces and still produces ham, and they had the leftover thyroid they didn't want to give to people that were eating their ham because they knew it would make them hyperthyroid, so they cut out the thyroid, and they had this thyroid available to start marketing and selling. It's a longer story than that, but basically that's what happened. It sort of went out of favor maybe about 30 or 40 years ago as more doctors started prescribing synthetic levothyroxine. However, in the last 15 years or so, there's been a more interest in using Armour thyroid and the desiccated thyroids, partially because patients aren't. I searched on the clinicaltrials.gov, and there's a study funded by Allergan starting in 2019, comparing armothyroid to synthetic Synthroid in previously hypothyroid participants. So we look forward to that study coming out. The next product is called MP Thyroid. It's made by Acela. It's an excellent product, readily available. It was recalled in 2020, but not since then. In 2021, CVS made a business decision not to stock MP Thyroid, saying it's on back order, which wasn't true. But as far as I can tell, it's now readily available even at CVS's. Now, the newest product I'm very excited about, and I'll try to explain why. It's called Adthyza. I'm not exactly sure how they got that name. It's something like actual add to your thyroid, something ZA. It's made by a company called Azurity, so maybe that Z is in there from that. It came out this year, just came out recently. It's a desiccated thyroid that comes in 16.25 milligrams, 32.5, 65 milligrams, and 97.5 milligrams and 130 milligrams. It's lactose-free, gluten-free, corn-free, dye-free, and latex-free. And I think it's going to be a game changer. I think this is a major company that focuses on innovative products that will meet the needs of patients with underserved conditions. And most interesting, the potencies of the T4 and T3 in Adthyza are confirmed with an LC, liquid chromatography assay, to ensure that the product meets USP specified standards. So each lot is individualized tested. On your bottle, you can see the lot numbers, and you can put them into a website and see that the lot has exactly how much it's supposed to have. And as you recall, the prior recurs were done because there was a variation in thyroid potency by lots. So this looks like they're taking advantage of that and making sure that each lot is properly contains the right amount of T4 and T3. And so far, it looks like it's covered by insurance. It may need a pre-auth, but I think it seems to be covered okay. They have what's called the Adthyza Cares program, and you can see that patients may pay as little as $30 a month, which is not that cheap, but in general, most of these desiccated thyroids and most medicines in general are going up in price. So it seems like it's a $90 for a 90-day supply, $35 for a 30-day supply. I think this is probably for once-a-day dosing, and since I give it twice a day, it might be more. This is with or without insurance. They have home delivery. They have free shipping with a 90-day supply, and everybody's eligible. So the most you would pay, according to this, is $90. I'm going to talk about Tyrosine. I like Tyrosine a lot. It's a gel capsule, and I take Tyrosine. It's a gel capsule with almost no binders or fillers. There's less interference with medicines. It doesn't need acid in your stomach for absorption, so you can take it with antacids. There's some idea that regular thyroid medicine you shouldn't be on things like omeprazole for proper absorption. It is often expensive and often not covered by insurance. They also have a liquid dose that's available. You sort of open up a little bag and break open each container and pop it in your mouth. One of the advantages I like about this is the liquid one. You can put the liquid, which is the lowest dose of liquid, which is 13 micrograms, put it in a glass of water, and only take half a glass of water one day and the other half the next day, and you can tighten yourself up. They have a huge number of doses now. They started with a 44, 62.5. So they have a lot of new doses available, which is really nice. And these are in either the capsules or the liquid. There is a generic Tyrosine. It's made by Lanet that also makes Unithroid. It's also a gel capsule that only contains levothyroxine, gelatin, glycerin, and water, so it's quite pure. There's no dyes, and it's gluten, lactose-free. It's made in Switzerland. It has similar dosing as the brand Tyrosine, although probably a little less. And I don't know about the price yet. It hasn't been clear to me if the price is less. I might imagine that it is. So this would be another option for people on Tyrosine. They can get a generic Tyrosine. Another product I haven't used much is called Thyroidity. It's made by a company called Vertice Specialty Group. It's an oral solution that has 100 micrograms for 5 mils. Its inactive ingredients include citric acid monohydrate, glycerin, methylparaben, sodium hydroxide, and purified water. You can enable gradual dose adjustments. It has a calibrated oral syringe that, according to the company, can meet your patient's unique needs. It's gluten-free, sulfur-free, and lactose-free. It's a package of 200 ml bottles. There's copay and savings cards there. So presumably, if you want to do 30 micrograms one day, you can do I guess it's going to be 0.15 mils. The next day, you can do a little bit more, whatever. You can adjust it within your doctor's guidance. So this has some advantage, but I'm not sure how much this is caught on. This is what it looks like here. There's a little syringe. It's 20 micrograms per mil. Some providers, including one somewhat alternative doctor in California, and some other people on different websites, advocate T3 alone treatment. T3 is called Cytodel, generic is levothyroxine. A paper in 2011 by Selly found that patients on T3 alone had lower weight and better lipid profiles than those on T4 alone. I often use combinations of T4 and T3, and sometimes they give T3 with desiccated thyroid, but some alternative doctors are providing only T3 to some patients. And I recommend against this for several reasons. First of all, several studies have shown that T4 gets in the brain much better than T3 does, and once it's in the brain, the T4 can get converted to T3. Therefore, if you're only on T3, the level of thyroid hormone in the brain might be quite low. Additionally, T4 has a long half-life and acts as like a reservoir, while the T3 has a short half-life and needs to be given several times a day if it's not in combination with T4. So I don't recommend T3 alone. I think it's also unphysiological to have a very low T4, which is what happens if somebody's only taking T3. However, it's interesting, if someone was misdiagnosed and really did not have hypothyroidism or has very mild hypothyroidism, the T4 could still be detectable or even normal when only on T3. So I usually do not give T3 alone, as I like the long-acting reservoir of the T4 along with the shorter-acting, quote-unquote, boost of the T3. Mary Shimon, who many people know, look at her website. It's listed here. She talks about recalls. This was a couple years ago. This was 2021. It's entitled, What's Really Going with the FDA in Natural Desiccated Thyroid? But I did want to mention it. I think it's important. I'll give you my take on it. She commented that back then in 2021, there were 3 companies making desiccated thyroid in the United States. 2 are small companies. Acela, which makes empty thyroid, has less than 200 employees, about 120 million in revenue. RLC, which at that time makes WP thyroid and Nature thyroid, has less than 50 employees. I'm not sure if they still have employees since they haven't made their product in a while, and around 30 million in annual revenues. AbbVie, which makes Armour Thyroid, employs 30,000 people in 75 countries and has an annual revenue of 30 billion, yes, billion a year. And it's behind huge armies of drug reps, marketing teams, and lobbyists on staff. And AbbVie recently acquired Allergen and Armour. AbbVie also makes the best-known brand of levothyroxine called Synthroid. Synthroid has the highest retail price of any brand name levothyroxine. Armour has the highest price of any retail of natural desiccated thyroid. And AbbVie's 2 thyroid drugs, in fact, frequently have a retail price that's more than double other brand names. I'm not sure this is still true. They have a political action committee that donates $1.5 million to candidates during the 2020 election cycle. And this is an important issue. The FDA may decide that natural desiccated thyroid is considered a new drug. Currently, thyroid medicine, desiccated thyroid is not FDA approved, nor is any drug, I think, with a few exceptions. And all the NDT drugs may have to go through a new drug application approval. A couple of years ago, FDA sent letters to Acela and RLC. They also indicated the FDA intends to change the design of NDT drugs to define them as biologics. More recently, on September 16, 2022, the FDA sent a letter to the National Association of Boards of Pharmacy, the NABP, that desiccated thyroid extract products can put quote-unquote put patients at harm, and the therapies containing DTA are biological products, which I put in bold, subject to licensure under so-and-so section of the PHS Act. The letter encouraged the ADPs to share this level with its members, the state boards of pharmacy. So the Alliance for Pharmacy Compounding expressed concern about the FDA implementing sort of this according to this letter from the Alliance for Pharmacy Compounding Products, concerned about a backdoor restriction on compounded desiccated thyroid that is problematic in its rationale and by communicating a novel approach. A letter from a branch chief to the Association of State Boards of Pharmacy rather than a definitive industrial communication. According to Mary Shimon and this other board here, these biologics are likely to be very extensive and require extensive FDA documentation. I asked my Adthyza rep and haven't heard back from him, but my guess is because Adthyza came on the market, they knew what was going on in the landscape, they decided to put a lot of money into making Adthyza. I don't think this is going to happen personally, but we will see. I'm going to next talk about this concept called reverse T3. And this is a sort of a new area, maybe a little bit controversial. It's actually interesting enough. I think Dr. Fauci was one of the co-authors of this. Probably different Fauci. Most of the circulating T3 is derived from 5' deiodination of circulating T4 in peripheral tissues by type 1 deiodinase. Deiodination of T4 can occur in the outer ring, producing T3, or in the inner ring, producing reverse T3 by type 3 deiodinases. You can see that on the picture there if you have any interest, and it's not that important. And the type 2 deiodinase also, and the pituitary also converts T4 to T3, is regulated differently from the type 1 deiodinase. So the thyroid has enzymes that can either make reverse T3, which is the inactive form, or the T3, which is the active form. Reverse T3 is biologically inactive and may block T3 from binding to the thyroid hormone receptor. Many years ago, endocrinologists realized that in severe illness, type 3 deiodinases increase, and reverse T3 is often high and T3 is often low. Endocrinologists termed this sick thyroid syndrome and noted that it was common in many types of chronic illness, especially in patients hospitalized in intensive care units. It was usually recommended that these patients not be treated with thyroid hormone, and in most cases, the elevated reverse T3 resolved when the patient's health returned. However, more recently, more alternative doctors, which are now often called functional medicine doctors, have made quite an issue about reverse T3. They argue, and I think this is basically correct, that a high reverse T3 is bad and can block T3 from binding to the thyroid hormone receptor. They also state, probably again correctly, that reverse T3 can go up in various conditions, including systemic illness, stress, inflammation, chronic pain, dieting, weight gain, and depression. And they quote articles showing that these diseases are correlated with a high reverse T3, but do not necessarily show that reverse T3 plays a significant role in disease. And they rely often very heavily on the reverse T3. They may have no other laboratory findings of hypothyroidism. They often give T3 only preparations to lower the reverse T3. Many of these patients come to see me and they don't really feel much better on this. And they haven't published on whether this is effective or not. They may treat a person with complete normal thyroid function test and put them on T3 to try to lower the reverse T3. And again, one of the functional medicine doctors in Los Angeles, he can't go into his office without getting a prescription for T3, no matter what your other labs look like. They look at sometimes a reverse T3 to T3 ratio as further indication to treat these patients. This outlines some of the factors that affect thyroid function, including the T4 to reverse T3 versus T3. Factors that increase T4 to T3 include stress, trauma, low-calorie diet, inflammation, toxins, infections, liver, kidney dysfunction, and certain medications. So what we decided to do is I had a couple of my students, Julian and Mayan, work on this. Julian started, Mayan's finishing up. And I was able to look at all my patients that I got T3 in. It just turned out there was a lot of them. It was 976 patients. We basically measured everybody that got T3. And these patients come to see me with the potential thyroid problems. And, I would say all these patients had signs and symptoms of hypothyroidism. All these patients come to see me with fatigue. I mean, that's a common reason why people come to see me. And they were on different thyroid preparations, which allowed me to look at the effect of different thyroid preparations when they first came to see me on reverse T3 levels. The patients who either had their labs done at Quest or LabCorp, I used a cutoff of 24 for reverse T3, as that would be above a certain cutoff. I didn't use any ratios. And we're trying to get this published and written up. I'm just waiting for Maya to do a little more analysis here. Hopefully she'll be finished soon. I did get IRB approval for this. It was a retrospective approval. But we're planning on submitting this shortly to probably clinical endocrinology. And you can see in here, here's the cutoff for 24. You can see here the patients on no medicines, percentage of them, about 9% of them have values above the cutoff here. And the patients that are on T4 alone are here. Those had the highest percentage. I'll show you the numbers in the next slide. These ones had the highest percentage of those above this cutoff of 24. This is called a box and whisker plot. While the people, for example, on desiccated thyroid were lower here, desiccated thyroid plus T3, there was none of them that were above the range. Desiccated thyroid plus T4, it was more of them above the range. So overall, the reverse T3 levels on T4 was 18.4. Not on T4 of anything was 15.2. This was extremely significant. And the percentage of patients with a reverse T3 above the cutoff of 24 was 17.7% on any type of levothyroxine treatment and 6.9% on non-treatment. Again, this was highly significant. The number of patients with reverse T3 above the range varied based on thyroid hormone replacement. The highest level percentage of patients with an elevated reverse T3 was 21% in those groups taking T4 alone. 9% of the patients not taking thyroid hormone replacement had an elevated reverse T3 value. In contrast, only 4% of the patients taking desiccated thyroid had a value above our reverse T3, compared to 12% taking a T3-4 combination, 17% taking a desiccated thyroid T4 combination. Patients on all type of levothyroxine treatment had a higher reverse T3 than those not on levothyroxine treatment, and the percentage of reverse T3 above the cutoff was much higher, as I showed in the last slide. We're doing some linear regressions still currently, but the linear regressions show that reverse T3 is correlated with free T4 levels, but not free T3 or TSH levels, at least right now. I didn't look at whether the reverse T3 was correlated with hypothyroid symptoms. We eventually plan to do that. And I do have some patients with a high reverse T3 are doing fine. Some with a low reverse T3 are not. But I think this is a valuable tool. I'm going to have a choice. I do try to reduce the reverse T3 in patients that are having symptoms with adding some extra T3 and maybe reducing their T4. So measuring reverse T3 may be helpful in some patients, especially those on thyroid treatments that contain T4. Patients that do have an elevated reverse T3 on thyroid treatment with either T4 alone or T4 plus desiccated thyroid may benefit from decreasing the amount of T4 given and increasing the amount of LT3 or myothyroid given or giving desiccated thyroid. I think this area of reverse T3 is an interesting area. There's a clear distinction between endocrinologists don't measure at all, except for me, and functional medicine doctors who do it about everybody and treat everybody for it. I think this test can be helpful in certain patients, but some discretion needs to be done who gets thyroid medicine, especially for the rest of their life, and who doesn't. So I would rarely use the reverse T3 for a patient that's not on thyroid medicine. The rest of their values are normal. I probably repeat it again. I just had a patient this week that had that. We're going to check her again. Most of the time it goes back to normal when they improve some of their other things, but I don't want to put people on thyroid medicine that really don't need it. This is more important for people that are already on thyroid medicine, that you want to adjust what they're taking. And next, talk about another interesting and controversial topic that I felt I needed to do a little research on to really clarify. The American Thyroid Association states that biotin use can result in falsely high levels of T4 and T3 and falsely low levels of TSH, leading to either a wrong diagnosis of hyperthyroidism or that the thyroid hormone dose is too high. The American Thyroid Association recommended people stop taking biotin for at least 2 days before thyroid testing to avoid the risk of having a misleading test. And this is because the test for measuring some of these hormones involves an assay that involves biotin in it. However, there's mostly case reports on this, and it seems to only happen if you're taking 20 milligrams a day or more of the biotin. Most supplements contain 10,000 micrograms or less, which is only 10 milligrams a day. So I think most people will be okay on this. They don't have to worry about this. I think this is a minor effect that's blown up by some people, but I think it's really minor. If you want to be sure, you can hold your biotin for 2 days before testing the thyroid. However, I did go to Quest and looked at what tests they say can interfere with biotin. And it's interesting, there's no TSH, free T4, free T3 on the test at all. There is TPO antibody, there's DHES, there's estradiol, there's testosterone, there's thyroglobulin, PTH. So there are some that potentially could do it, but I think, again, it's mostly in those that are on higher doses, and you don't have to worry about it. I'm going to conclude by talking about a thyroid diet. And I recommend a thyroid diet as a clean diet, just like I recommend for all my patients. Lots of fruits and vegetables, limit processed foods, minimal simple carbs or high protein. Otherwise, there's really little data on any specific diets for people with thyroid disease. Just a clean diet. Functional doctors often promote diets that address leaky gut, a condition not recommended by physicians. Anti-inflammatory review articles on Hashimoto's do not consider Hashimoto's as a disease of inflammation. So basically, I don't see a need for gluten-free. If you want to try it, you can. I haven't found that patients do not much better on it for the thyroid, and there really isn't much data on that. There was an article on Medscape by Angela Leung, a thyroid diet, is there such a thing? That she talks about, the same things I did, a healthy diet. This is a review article on some causes of Hashimoto's. There's no discussion of inflammation, and there's no discussion of gluten. And I actually didn't show the slide here, but there is a slide showing the structure of gluten and the structure of the TPO is completely different. So some doctors seem to say they're similar, but they're not at all similar. And what can you do? Another thing I want to mention is selenium. Selenium increases T4 to T3 conversion and reduces TPO antibodies, so it's quite helpful. Patients with untreated growth hormone deficiency have decreased T4 to T3 conversion, so they may likely benefit from selenium, but also benefit from growth hormone treatments. However, there's some studies that show selenium increases the rate of diabetes. So I'm cautious about giving selenium to those patients with prediabetes or diabetes, or those with a family history of it. But selenium could be helpful, but again, it's not going to be all and end all. So the overall, the thyroid diet is to eat a healthy diet, exercise, and have your thyroid properly treated and tested. So overall, special thanks to my social media expert, Tiffany, who arranged the Facebook group. Tiffany, you're doing a great job. We'll post the talk in a couple of days. And we have some time for chat questions now. So people can put on the chat. People say, oh, so we can see you. Thank you. So did anybody have any questions? Please ask in the chat. How long does it take to feel better on Adthyza? Katie asked. Well, in general, in thyroid medicine, you need to give it a little bit of time. It just doesn't work overnight. Adthyza is just like the other ones, so I would give it probably, like a month is a good time. People in general need some time for their thyroid hormones to correct, and then once they correct, you need some time to feel better. So, maybe a month or two would be reasonable. Now, Tiffany, are people doing chats on Facebook that you want to read off to me?
Oops, 1 second. Hi, yes, just give me one moment. I'm waiting for people to chat in.
On the Facebook?
Yes.
How many people are on Facebook?
About 15.
15, okay, great.
Here's a question from Don. What does low RT3 mean? Mine was 6.
So low is good. High is the problem. So you can't be too thin, too rich, or have too low of a reverse T3. I guess it's probably not completely true. But low is good.
Okay, great.
Betsy asked, what causes central hypothyroidism, and what's the best thyroid medicine for it? So central hypothyroidism is due to a pituitary or hypothalamic problem, mostly a pituitary problem. Some people can get it just without having previous surgeries or radiation, but many people have had surgeries and radiation. The treatment's the same. I think those people also do quite well in desiccated thyroid or T4, T3 combination. Lori asked if reverse T3 blocks receptors for T3, then why would T3 supplementation help? Because it sort of kicks out the reverse T3 from the receptor. They're in equilibrium, and the T3 can kick it out and reduce the reverse T3. Marlene asked, a girl in one of my groups contacted Adthyza and asked what the fillers are derived of. They told them the glucose dextrose is made from corn, yet their website says it is free from corn, and a way of finding out the truth. Yeah, I could try to ask my Adthyza representative about that. That's a good question. Janet asked, in the studies talking about T4, T3 combination, is that levothyroxine and cytomel? Yes, that's what it is. It's not levothyroxine desiccated thyroid. It's the T4, T3 combination is levothyroxine and liothyroidine. Jan asked, I have an AFib. You say it's being on desiccated thyroid is risky. I think it's more risky, and I think in your case, if you have AFib, you don't want to have a suppressed TSH. You want to keep your TSH in the normal range. Can biologicals be compounded? Yes. So what happens is the companies that RLC that make the Nature-Throid have been able to supply compounding pharmacies with a raw ingredient. It's called thyroid from USP Thyroid. And so you can get desiccated thyroid compounded. Not all compounding pharmacies do it, and not all just do as good as others, but it can be compounded. Deb asks, would low ferritin impact the reverse C3? I'm not sure the answer to that question. At least in theory, it might. We certainly didn't look at it yet, but we may look at that in the future. What else you got on the Facebook chat?
Amy asked, for someone diagnosed with Hashimoto's, do you recommend testing for potential other autoimmune diseases?
Yes. So people with autoimmune thyroid can have other autoimmune diseases, especially Addison's disease, pernicious anemia, celiac disease, sort of a type 1 type of diabetes.
Okay.
Marlene asks, yes, but if the FDA turns NDT into biological, then would it be able to be compounded? I think that's the concern. If it is a biological, they may put more hoops for the compounding pharmacies. That's a good question. I think so. I don't think they're going to do that. Is it difficult to get the dose precise with desiccated thyroid? Not that difficult. I mean, I think you have to do blood tests and you have to monitor it like the other people. But I don't think it's any more harder than T4 alone. Do you have a recommendation for optimal ferritin, vitamin D, and zinc levels? Ferritin I like above 70, say 70 to 130 or so. Vitamin D I like it between 30 and 50. Zinc I don't have optimal levels for. Curious why you think Adthyza is there a benefit over Armor? I do think it's better made. I like the fact that they test each lot. I think it's a company that's really investing into this and they want to make a great product. I think Armor is just going to be one of many products they bought from another company they're less invested in.
Okay, one more question from Tara. If someone develops central hypothyroidism after pituitary surgery, is there a chance that it can eventually resolve as the pituitary heals?
Yes, definitely. So I've had several patients that either had surgery or Sheehan syndrome or some other cause that with time the thyroid does recover. And they're able to get off medicines. Usually cortisol is the one they can get off first, growth hormone the last, and thyroid sort of in the middle there.
Dawn asked, have you found COVID disrupting thyroid levels if you have Hashimoto's?
Yeah, so COVID can, I think during acute COVID, you can be quite sick and your thyroid levels can be off. I think once it's treated, you sort of return back to normal. How does one go about switching from T4, T3 combination to Armor? Could you do it cold turkey? Yes, you can do it cold turkey, but, the dose is going to be different, and the dose is going to be somewhat of a guess on how much you're going to need once you do the switching.
Margaret said, just saying hello to my favorite doctor ever.
Hi, Margaret. Thank you. Any other Facebook questions?
Not right now. I think that's it.
So we'll post it shortly. Thanks, everybody, for joining.
Thank you, Dr. Friedman.
Okay, bye-bye.
Bye-bye. Thank you.
Thank you.